Good morning, everybody. Welcome to the April ASAM Technical Assistance Series. Today we'll be discussing the results from the provider alignment reviews. And before we get started, I'm going to go ahead and read the wiretap law. So in accordance with the Wiretap Act, it is against the law in Pennsylvania to record oral conversations without the permission of the folks involved in most circumstances. This session is being recorded for training and/or record-keeping purposes. By participating in this session, you are consenting to the recording, retention, and use of this session. At any time, if you have a question or comment, please feel free to place that in the chat and we will respond to you as soon as possible. If there happens to be an opportunity where the question or comment would be verbal, then please note that by commenting verbally or questioning verbally, you are consenting to the recording, retention, and use of your statements recorded as part of the session. Please exit this call at this time if you do not want to be recorded. We will be able to review the video in its entirety on the DDAP webpage following this event. We'll go ahead and get started. If you have questions or suggestions for future calls, or if you have a question you'd like to ask, please do so in advance of the upcoming webinars. We ask for 7 days. You can always submit questions to our resource account. That address is shown here. Suggestions for future topics are welcome. Today, we have a few members of the Mercer team, Lori Plancher, Stacy Smith, and Brenda Jackson. I'll be taking you through the results of the alignment reviews. And as part of today's conversation, we will discuss, we'll discuss the results of the on-site alignment reviews. Alignment of the ASAM criteria is required of treatment providers that receive funding for providing treatment services under agreements with single county authorities and managed care organizations. DDAP strongly suggests reading the ASAM in its entirety, the ASAM text, attending the ASAM training, and reviewing the resources available through the documents on DDAP's webpage. Here are today's learning objectives. And I will now turn it over to the Mercer team.
Thank you so much, Gloria. So what we're going to do today is talk a little bit about the purpose of the reviews. We're going to answer questions about the status of the reviews, and we're going to be telling you what the findings are. This is the first time this information has been widely available. And if you have questions, we'd ask that you put them in the chat. We'll be monitoring the chat. And if we don't get to your questions, we will be answering them in an FAQ document on the website. So if you go to the next slide, we want to talk to you a little bit about the demonstration. There is a substance use 1115 demonstration that has been granted by the Centers for Medicare and Medicaid Services for large substance use residential facilities that are over 16 beds that are traditionally not funded by Medicaid. What is happening is the Centers for Medicare and Medicaid Services, or CMS, has agreed to fund those facilities if they become aligned with ASAM and medication-assisted treatment requirements. And because of that, we're going to be looking at what those requirements are, what the state is doing to make sure that providers are in alignment with those requirements, and how the providers are doing. Please note that the state law requires the use of the ASAM 3rd edition. If you go to the next slide, the first requirement of the demonstration in order to receive the federal funds is that there must be widespread use of the evidence-based SUD patient placement criteria, such that, first of all, providers use the ASAM multidimensional assessment tools to guide assessment treatment needs. Second of all, that beneficiaries access substance use services at the appropriate ASAM level of care. Third, that the interventions are appropriate for the diagnosis and the ASAM level of care. And fourth is that there is an independent review of placement in residential settings by an independent third party, which would be, in this case, the BIMCOs and the primary contractors, as well as the SCAs. If you go to the next slide, the next requirement is that the state must use ASAM to set residential treatment provider qualifications for the use in Medicaid, and that those standards must include service types, clinical hours, and staff credentials at a minimum, and that there must be a state process to review residential treatment providers to ensure compliance with those ASAM standards. This is the primary goal of these on-site residential reviews. In addition, residential providers are required to offer medication-assisted treatment on-site or facilitate access off-site to medication-assisted treatment. If you go to the next slide, milestone number 4 requires, under the demonstration, that the Commonwealth complete an assessment of the availability of providers and accepting new patients to ensure that there's sufficient provider capacity at the critical levels of care, including medication assisted treatment for OUD. So part of the on-site reviews is that the review team will be looking at the number of beds in each residential facility and ensuring or seeing if there are open beds and if there's capacity in that facility. If you go to the next slide, we're going to turn this over to Lori Clancher.
Good morning, everybody. Nice to see some familiar names. Hope everyone's well. And so talking about, again, the purpose of the reviews. So these reviews are intended to assess provider ASAM alignment. They're not intended to be quality or licensure or FWA reviews, although we know that as you do the reviews, some of those findings might be identified. And so if that happens, the reviewers should follow the usual procedure to follow up on those items. But again, it's not the primary function of the alignment reviews. Hopefully you're familiar with the scoring areas of 1 to 4, with 1 being substantial compliance and 4 being not aligned in significant key areas. And if you're not aligned in a significant key area, the follow-up you can see is a very short window. The significant key areas are ones that Brenda mentioned in the milestones. So application of ASAM placement criteria, the use of a comprehensive social assessment, which then is used to drive treatment with an individualized treatment plan, as well as an individualized length of stay, and also education about and referral to medication-assisted treatment if it's appropriate and the member desires that. Next slide, please. All right, so this is the status of the reviews that were done to date. And you can see that scoring both on medical record reviews and the infrastructure reviews, and you can see where those align. And so the horizontal numbers are the infrastructure reviews, the vertical numbers are the medical record reviews. And if we go to the next slide, we'll dig into the findings a little bit more. And so if you can see this, that the scores for the infrastructure are really very positive. Most providers scored a 1 or a 2 on the infrastructure review. And so not surprisingly, you can see that the record reviews are largely in the 3 to 4 rating. So, you know, a little reversed. And so I don't want anyone to be alarmed by that or think that it's a really dismal finding. Many things are being done correctly with just a couple of critical missing items. And so really the key is to determine if things are being done reliably. And if that's the case, then, you know, maybe the documentation needs to be firmed up. Or if they're not being done reliably, what are the steps to put the actual policies and procedures that were found on the infrastructure review in place. And we do want to really recognize the considerable amount of change that all of you providers have had to manage with the transition, and recognize the hard work you've put into this. So if we look at this, we can see that there were 9 providers who had a 1 meaning substantial compliance on the infrastructure review and the medical record review. And then there were 43 providers who had a 1 substantial compliance and a 4 on the medical record review, indicating a need for follow-up in those critical areas. You can go on to the next slide. All right. I wanted to recognize some of the providers that these are the 9s that had the best scores. I do want to point out, even though there's a BIMCO assigned to them, it doesn't mean that these providers are only limited to that BIMCO. Of course, you know, many providers are cross-contracted across all of the BIMCOs in Pennsylvania. But shout outs to Gaudenzia's, Endless Mountain, Gateway Erie, Granitesville, Stairways, and Firetree. Perhaps there's an opportunity at some point for these agencies to share any best practices with others, because we know that this is quite an accomplishment. So congratulations and thank you. You can go to the next slide. This really gets into the highest scored items of the infrastructure review. And what's really exciting to see here is that these are core activities. So use of the admission criteria, using the comprehensive biopsychosocial, doing continued service reviews that are individualized, and the documentation also indicates that there isn't a fixed length of stay for the program. And you can see that the level of care is listed here too. So most of these are all but 3.7 WM. And then the final item on here, 7.02, about planned clinical program activities. That's specific to the 3.5 level of care. But you can see these scores in the high 90s, which is really great. Go to the next slide. And so similarly, this is for the record review, and these scores align nicely with the items on the infrastructure review, right? And again, these are either all but WM, withdrawal management, or specific to 3.1. But again, scores in the high 90s or 100% for using the admission criteria, conducting the biopsychosocial assessment, it's individualized, and doing individualized treatment. I'll turn it back over to Brenda to go through some of the scores that were not as high.
So I'm going to go through the lowest scored items on the infrastructure review. Now, the first thing we want to make sure that you all see is on this page, the lowest scored item had 79.6% compliance of the 3.1 and 3.5s. 79% is still an extremely high number of compliance. So that means a vast majority of the providers are actually getting this correct. And so as we go through this for the lowest scored items, which is what Stacy and I will be following up in the next 6 or 7 slides, you're going to see that even the lowest scored items are still extremely high. What that means is there's really only 1 or 2 crucial items that providers might be missing. And that it isn't one thing that everyone's missing. It's just that 1 or 2 things here or there. So if you look at, for example, item 3.4B, for level of care 3.7, we see that 88.6% of the providers are actually having a policy in place that the physical exam must be performed by a physician within 24 hours of admission. We also see for level 3.7 WM, 94.9% of the providers are saying that if the level 3.7 WM services are a step down from level 4 WM, that there is a policy in place that records a physical exam within the preceding 7 days is reviewed by a physician within 24 hours of admission. The bottom item is that for levels 3.1 and 3.5, 79% of the providers are showing that there is a random drug screening to shape behavior and reinforce the treatment gains as appropriate to the patient's individual treatment plan. And again, these are about policies and procedures being in place. If you go to the next slide, You'll notice here for item level of care 3.5, 94.9% of providers said that there was evidence of how programming was adapted to the developmental stage of the patient and the level of comprehension and understanding and physical abilities of the individual. And in level 3.5, 94.3% of facilities had evidence of a policy that strategies were appropriate to the patient's stage of readiness and desire to change. For the next one, for levels 3.1 and 3.5, 91% of providers had a policy and procedure that physicians or physician extenders were available 24 hours a day, 7 days per week by phone or in person. For the next one, levels 3.7, 85% of providers said that they had a policy and procedure in place that the facility had evidence that psychiatric services were available within 8 hours by telephone or 24 hours in person, and that the facility had an available licensed practitioner who is specialty trained or had experience in addiction medicine or addiction psychiatry. If you go to the next slide, this is the record review, and I'm going to turn that over to Stacy.
Thanks, Brenda. So like Brenda said, we're going to focus on the record review. So this should reflect the policies and procedures that you have either developed or revised to reflect the ASAM level of care that you're providing. When you're looking at your reports for the record review section, it's important to look at your program and determine first, is your program providing the area that's identified as a growth if you have an area that's been marked low? And then if your program is providing that service or function that's been identified as an area of growth, what might be some of the barriers to staff consistently and clearly documenting that that service or function was provided? As both Brenda and Lori said, overall, even though these are low scored items, they really aren't low. So the first slide looks at areas of growth for all levels of care. There are 3 areas that address treatment planning. The first being evidence that the treatment plan includes articulation of short-term measurable treatment goals. 76.7 of ASAM 3.1 providers actually met this requirement, and for 3.5 and 3.7, 86.7% met this requirement. The second area around treatment planning was that it's regularly reviewed, and any significant events or changes that occurred are documented, and then adjustments are made to the plan accordingly. For all levels of care, it was found that 82.4% of providers actually met this. The last area related to treatment plan. Treatment planning includes the articulation of short-term measurable treatment goals. We saw 76.7% of ASAM 3.1s meeting this requirement, and 86.7% of ASAM 3.5 and 3.7s meeting this requirement. Another area that applies to all levels of care is documentation of communication with other levels of care and referred services being present. We found that 80.5% of all levels of care actually met this requirement. And then the last area is documentation of review of all 6 ASAM criteria dimensions as it relates to discharge and transfer functions. And we found that 72.3% of providers met this criteria. If we move to the next slide, we start to look at specific levels of care. This slide looks at the lowest scored items for ASAM 3.1. The areas of opportunity for these programs include ensuring that at least 5 hours a week of planned clinical programming and activities are available. And we found that 79.6% of providers actually met this requirement. The second area is evidence in the medical record that shows that random drug screenings were done in accordance with the individual's treatment plan. We found that 58.6% of providers met this requirement. Again, this could be happening and it's just a documentation issue, especially if a urine drug screen is offered and a person declines, making sure that staff knows, document that offering and that individual declining, because that does demonstrate that your program is offering the services as written in the treatment plan. However, the individual always maintains the right to determine if they want to or don't want to participate in a urine drug screen. Unless they have justice involvement, they still have the right to refuse, but you want to make sure you're making them aware of possible repercussions. But back to the main point, making sure that staff are consistently documenting when they're offering that intervention to individuals could be what's making this a little bit lower than some other areas. The last 3.1 specific area is evidence in the medical record that shows that services for the individual's family and significant others were offered, and if they accepted those services, documenting what services were provided. Again, this could be another area where it's just staff not documenting that outreach and that possible refusal, which would show that your program is meeting this requirement. But again, people have the right to refuse services, so having that documentation could be really helpful in showing that your program is providing this function. If we go to the next slide, we're looking at ASAM level 3.5 specifically. This one goes into urine drug screens a little bit more. It looks at first, were urine drug screens included in the treatment plan as an intervention? And we saw that 23.4% of programs had this. And then if they were included in the treatment plan, did the random drug screens occur? And we found that 62.1% of programs met this requirement. It's important to note that the completion of random drug screens is never a goal of treatment. However, it is an intervention that can be useful in helping build a therapeutic alliance and helping individuals meet their treatment goal and track their progress. The individual always maintains the right to refuse a urine drug screen when it's offered, but the offering and the refusal should be documented in the notes and in the treatment plan to demonstrate that the program is providing that intervention. And like I said before, if the individual has any kind of justice involvement, making sure they're aware of any external repercussions that could happen if they refuse to complete a urine drug screen, and that they have the information they need to make an informed decision. The next area is documentation for daily professional services being provided during the treatment episode. We found that 88.7% of programs met this. Another area of opportunity is the medical records, including services for family and significant others, similar to ASAM 3.1. And if those services were accepted, that documentation shows who they were offered to, what was offered. We found that 63.6% of 3.5s met, including services for offering services, and that 79.8% showed documentation that services were accepted. The last area for 3.5s that's an area of opportunity is individuals needing consultation and emergency services have access to those services. We found that 82.5% of providers met this requirement. If we go to the next slide, we're going to look at ASAM level 3.7. The first area of opportunity is evidence that there's counseling and clinical monitoring provided that promotes involvement or re-involvement in skill building. We found that 81.5% of providers met this requirement. And then similar to 3.1 and 3.5, looking at offering services to family and significant others, and then if they accept, documenting what was provided to family members and significant others. The ASAM 3.7 levels had 85.2%. They found that services were provided. when the family accepted them, and it was offered to 74.1%. Last slide looks at ASAM 3.7 WM. Some areas of opportunity included ensuring that documentation shows a range of cognitive, behavioral, medical, mental health, and other therapies designed to enhance the patient's understanding of addiction, completion of withdrawal management, and referral to another level of care was provided. We found that 78.6% of programs met this requirement. And we found that 90% of ASAM level 3.7 WMs provided health and education services, including things like education on HIV, Hep C, tuberculosis. We found that 87.4% of 3.7 WMs had documentation that showed a physician, PA, or ARNP was available to provide on-site monitoring and evaluate care on a daily basis. We found that 86.6% of programs had evidence that the biopsychosocial assessment was used to determine the level of care where the patient was placed, and 72.4% used that biopsychosocial to identify treatment priorities in the individualized plan of care. And then finally, we found that 52.7% of 3.7 WM providers had problem identification in dimensions 2 through 6. 71% had treatment goals and measurable treatment objectives, and 75.4% had activities to meet the objectives identified in the treatment plan. So again, it's a question of if your program had a lower score in one of these areas, first figuring out, is the service provided? If no, then what needs to change to make sure it is provided? If yes, what are some of the barriers to staff completing documentation in a way that consistently and clearly demonstrates that these items are met? And we can go to the next slide. And I believe we're going to open it up for questions at this point. I'm getting a nod, so that's correct. And I think we're going to use the chat function for that. So if anyone has any questions or comments or thoughts, please feel free to put them in chat. I'm not sure if we have the ability to let people come off of mute or not, but chat is definitely working.
We can give it a minute or two for people to give you time to enter any questions you might have. We will share the slides. We post them to our ASAM transition page, which I believe is, somebody put that in the chat.
There's a question about lower levels of care. At this point in time, DDAP and OMSAS are working through what the process will look like for lower levels of care. I don't think there's been a formal decision about exactly how that will work yet. We have some challenges around adding random screens to the treatment plan as a staple intervention. Does the addition of this to the treatment plan update cover this requirement? I'm not sure I understand that question. That's from Jeff Thomas. Does that might be something that we'll have to work with that particular provider directly with? Is that random drug screening, Stacy?
I think so. So adding it to the treatment plan would meet the requirement. I think when adding it, you want to add it in a meaningful way and inform the individual on some of the benefits of completing random screens and letting them know that, again, folks have the right to refuse treatment. Just because it's added as an intervention and they agree to it on Tuesday doesn't mean next Tuesday when you offer the random drug screen, they have to complete it. A lot of the research shows that using random drug screens and substance use treatment can be a valuable tool for building therapeutic alliance, for looking at progress as substances kind of leave the body and being able to track where the person's at, especially with withdrawal management. And then it can help have some conversations if a person returns to use without it being used as a kind of gotcha moment. So I think letting folks know this is a valuable part of your plan. Just because it's in there, you don't have to complete every one that we offer you, but it is a tool that can be used, would be helpful. And I think we have some other research and literature on using urine drug screens in substance use treatment that aligns with the ASAM requirements, because it is identified in ASAM as something programs should be offering and using. Does that help, Jeff?
Yes. So I think, the biggest challenge around drug screens is the complexities of some of the drugs that are available today. Some of the drugs are not detectable. Some of those drugs turn up as a positive result for a patient who is on a current medication for withdrawal management. And there are, excuse me, there are some difficulties in terms of knowing how long that should stay in the system. So we sometimes run into conflicts with patients who believe that the result is in error and it does impact rapport. So really what we were looking at doing is, instead of making it a part of the treatment plan to begin with, we inform the patient that they will have random drug screens, but it's not necessarily listed as a particular intervention. We do the random screens at random times throughout the stay. And then we were documenting that in the treatment plan update as having occurred.
Okay, so that makes sense. It sounds like it's one of those cases where the documentation isn't fully lining up with what the requirements are. So the ASAM requirements would really like to see the documentation of the random drug screens in the treatment plan.
Okay.
And just being really transparent with them, letting them know just because this is in here doesn't mean we're requiring you to do it every time. Because it sounds like you all are taking that person-centered approach when you actually complete the random drug screens. It sounds like it's just missing in that one place that the tool is looking for it to be in.
Yeah, I think this is one of the areas where sometimes research forgets the impact about how a patient feels about their treatment. And it sounds simple and reasonable in theory, but in practice, it does impact rapport.
Yeah.
Thank you.
Thank you.
Stacy, the next question is also on UDS. It is from Kirsten Kennedy. Can you speak more on the continued need for UDS to be an intervention on client-centered treatment plan for residential level of care? I think we've handled that, but is there more there, Kristen, that we need to address? We'll take that as we've addressed it. So Carlene Ricketts had a question about the ASAM 3rd edition. That is what state law requires. And the 4th edition will not be used until the state law is changed, is my understanding. Will the ASAM audit findings be available for each provider online, such as the licensing audit outcomes? It's my understanding, Billy, that you will be provided a copy of your ASAM alignment results from each of your reviewers. So as you are the the facility, you will get a copy of them. And Gloria, do you want to jump in with a response on that?
Sorry, I was trying to enable Kristen's mic. Can you repeat
Oh.
that?
Sorry. We just want to verify that the ASAM alignment review results will be given to each provider by the reviewer. It is not the intent that they will be online.
That's my understanding. If I'm not correct in that, I can certainly get back to you on that at another time, but I don't think that we'll be posting it online that I know of.
That's correct. We will not be posting it online, Gloria.
Thank you, Jen. Thank you.
You're welcome.
And there's a question about the frequency of the reviews. So I think it was a slide, there was a slide that showed it's based on the compliance. So full compliance. Sorry, I'm trying to go back to my slide.
We go back to slide number 10, Gloria.
There we
Slide
go.
number 10, Gloria. Thank you.
There we go. So for providers that score a 1 and a 1, that's substantial compliance. The reviews are every 3 years. And then, there's some flexibility with the other frequency of review. So not aligned in minor areas, 1 to 2 years, not aligned in primary areas, 6 months to 1 year. But the follow-up for the not aligned in significant areas is obviously much tighter because those are crucial indicators. So that's a 3 to 6 months. And once a provider reaches the substantial compliance, then the 3-year time frame starts.
The next question is about random UDS required in withdrawal management. We would have, I don't remember off the top of my head exactly what that looks at. We will have to probably go back and look at the tool. The answer is in ASAM on pages 137 through 141. And just know that if it is required in ASAM, it is required on the audit, unless Stacy or Lori know that one off the top of their head.
I'm taking a look. I think, some of this has some clinical finesse to it, right? So if you're trying to just get a feel, if the person is using what they say they were doing, then it might be a tool. But yes, absolutely, you would expect to see some of the, drugs in their system as they go through withdrawal management. And yes, I know, in fact, right, people could be in a program and having not used, and then they test positive. And so I think that's probably just a, kind of a clinical protocol that you would have to look at if you're thinking that the person is, having, metabolites show up in their urine, testing positive.
And just to add to the urine drug screens and withdrawal management, there have been a lot of cases of individuals not realizing that the substances they were using have other substances cut into them. So just because a person says they're using opioids doesn't mean it might not have also fentanyl in it. So that might be something that they aren't aware of themselves even in reporting. So especially at admission for withdrawal management, it's a really good idea, and also required by ASAM to get that urine drug screen completed. So not only the treatment program knows the full array of substances they're going to support that person through withdrawal with, but also so that person has some idea, because they honestly might be unaware of what other substances have been added to the substances that they're purchasing and using.
So can I just clarify I'm sorry, I don't know why that's doing that. I'm just trying to find out, not the initial UDS, but are you talking about additional randoms in withdrawal management?
I think this one, Kimberly, we're going to go back, research it, and get back with you. And again, we're looking directly at ASAM, so that's what we'll be looking at, and we'll get a firm answer in writing, and it'll go on the website. Okay. And I think, Kimberly, that answers both your random UDS as well as the metabolic question. Okay, I see a nod. Excellent. Okay, and Kirsten was saying that it was covered. David had a question. We were given notes that members should have treatment plan goals, including MAT, medical, and mental health. If the member does not have any of those concerns based off of the psychosocial, will they be looking for any of this in the treatment plan? Well, first of all, if any of those are identified in the biopsychosocial assessment, we would expect to see it in the treatment plan. Lori and Stacy, do you have thoughts about what if it's not identified in the biopsychosocial?
Yeah, I mean, the biopsychosocial was designed to, support the treatment plan. So if it's clearly documented that, the person isn't a candidate for or isn't interested in any medication, has no significant medical history or behavioral health needs other than their substance use, then, you wouldn't necessarily see it as a goal. There might be something for continued support or something like that.
I would point out, though, that we are looking to make sure everyone is offered medication-assisted treatment when it is appropriate. Mm-hmm. That is a requirement of the demonstration. Okay, Justin Wolford, will these follow-up reviews occur in conjunction with annual licensing, or will they be separate reviews? At this point in time, we are anticipating that the alignment reviews will be separate and will continue to be separate. But as Lori pointed out, if there is something that is identified on the review that is related to licensure or quality, it will be referred to licensure or quality. I think that's all the questions in the meeting chat. Any other questions, comments?
Brenda, one question, and I'm not sure if you answered this or not. Will there be ASAM reviews for lower levels of care?
Yes, and at this point in time, this Commonwealth, DDAP, and OMSAS are working together to determine how to proceed on the lower levels of care. There are, as we noted at the very beginning, some requirements related to all ASAM levels of care about providers using biopsychosocial assessments to drive treatment plans, about the interventions being appropriate for the level of care and the diagnosis, and about the patient placement being driven by the assessments. So there are some demonstration requirements, and I think that there will be some announcements later on about exactly how the lower levels of care will proceed, as well as care for adolescents.
And then I believe there was one more, whether we're or when we'll be moving one to the 4th edition. Do you want to touch on that?
I did say right now in state law, the 3rd edition is required. And so until there is a state law change, you will be using the 3rd edition.
Thank you. Mm-hmm. Anyone else have any questions? You have a minute or two if you want to type that in the chat. If we didn't get to your question, or if you have additional questions, you can always email the ASAM resource account. the link that you see on your screen should be a live link. It'll take you right to the email. You can always send us a question and we will research the answer and get back to you. And next month's webinar, we are planning to address traumatic brain injuries across level of cares. So hopefully you can join in for that as well. And we can give it another minute if you like. But thank you very much, Stacy, Brenda, and Laurie. Very, very informative for the field, both in results and moving forward expectations for the on-site alignment reviews.
And thank you to the provider network for your cooperation with this. We know it's been a big lift for you, and so great job, and we look forward to continuing it.
And Rachel, about the adolescent programs, there will be an announcement forthcoming on that.
If there aren't any more questions, this does conclude our webinar for today. Thank you very much for joining us. Oh, I see somebody. Jody, did you raise your hand?
I did.
Okay, just jump in.
This is really maybe I just want to bring back the urine drug screen question. Just to make sure I understand this correctly, because the feds with the new opioid treatment standards have kind of backed off on labs and really making it so that individuals are not kind of forced into urine drug screens and labs, et cetera, but making it so that clients are feeling safe and comfortable and that you're working with them. So as long as providers document that they've worked with individuals with urines, they're good.
I would go a little bit farther than that, Jody. We are expecting to see in the treatment plan random drug screening as a treatment intervention. That is a requirement of ASAM.
So the ASAM language, does say as appropriate to their individual
Yeah.
treatment plan. So again, I think this gets into the documentation as to, if you're not going to do that, why is it not appropriate for this person? So that is clear in there. And certainly, yes, we've moved beyond hopefully it being a punitive thing and really being, a more of a supportive intervention. But yeah, the ASAM does say it's to shape behavior and reinforce treatment gains as appropriate. So.
Okay, so you don't want them to document a negative, right? That's not what I heard, I hope, right? I'm just trying to get it clear.
Oh, you mean as far as the results?
No. I guess what I'm asking is like federally, right? What they're saying as far as labs and urines is that working with individuals and where they are, the goal is, especially with opioid use disorder, is to meet people where they are and not force them into situations. And that's, I'm sure, knowing what I know clinically, where ASAM, what I know, really be where meet people where they're at. So documentation is extremely important. So as long as if clinically individuals, if it's part of the treatment plan and they're documenting that they're doing what they can, and doesn't have to be elaborate documentation, because the admin burden on our providers is extremely difficult. And those providers that got 9s are way to go. That's really amazing. I mean, that's incredible. And I'm just asking, as far as the documentation goes, federally, in regulation, we're saying that, you know, do what you can as far as getting these labs, getting these tests done. But if it's not done, okay, do what you can do. Just document it. But
Yeah,
it
so
doesn't have to be elaborate.
yes, I think the step one is to determine if random urine drug screen would be an appropriate treatment intervention for a person.
Mhm.
And they agree, right? Because they have the right to refuse, aside for people who might be mandated, for treatment, right? Otherwise, interventions are recommended but not mandatory, right? And so then, if it's not done, you document why the person refused. I don't know why ever it happened, or that it did happen, and if you're planning to change it, right? You want to change the frequency or something like that. So, yeah, you just document that in the treatment plan or the progress note, and that should be acceptable.
Okay, and then if it's not appropriate for whatever reason, they can just move on. They don't have to continue to document.
Yeah, if it's determined that it's not a treatment intervention for that person, then you wouldn't list it as one.
Okay, good. All right. I just wouldn't want providers to have to continue to document something that isn't necessary. Okay, thank you.
There's a follow-up from Paul Cannon. I think the continuing challenge with UDS is with the phrase "as appropriate to individuals' treatment plan." There continues to be disagreement between most clinicians and most clients on the value of UDS in treatment.
Right. So I would say it might be agency specific, right? And everyone probably has a protocol on the use of urine drug screens.
They should.
Yeah.
According to the infrastructure review, every agency should have a policy, and ASAM generally requires that treatment plans address whether there will be random drug screens as an intervention, is my understanding. Did I get that right, Lori?
Yeah, that would be my understanding, that something like that should exist. And it may vary, of course, from agency to agency. And because I agree with you, Paul, with the way urine drug screens have been used in the past versus the way they're probably being used now is changing.
But ASAM requires there to be a policy and to address it one way or the other in the treatment plan. And then, as Stacy pointed out, on any given day, there's the right of refusal, which requires documentation. I think that what was being brought up in the internal conversations is, if there's no policy and there's no mention of it in the treatment plan, and then there's no documentation, I think that's what was being, the concern was.
Thank you, everybody, for engaging in this conversation. We hope to see you in May. I think this does conclude this morning's webinar. So please have a lovely Monday, even if it's raining and cloudy where you are. Enjoy your day and your week, and we hope to see you next month. Thank you, everybody from Mercer as well.
Take care, everybody.
Take care.